Thank you, Mr. Chairman, ladies and gentlemen. In my presentation, I will discuss the benefits of the national solution that Niilo Saranummi presented in the previous presentation. My point of view is that of a clinician and his patients. I'm a part-time general practitioner myself. Let's first define what is health information. Jeremy Wyatt divided health information into three types. The first is medical knowledge. That includes not only evidence-based medicine, but also clinical skills, how to do tricks and things. The second is patient data on individual patients, and the third is directory information or information of the infrastructure of healthcare, often neglected but very important in health systems. The emphasis in my presentation will be how patient data is used, linked with and in context with the other types of information. So there are two important principles. Wherever X files this patient data is stored in, it's important that the data is available at the point when they are needed. Otherwise, the data are totally useless. And the other important point is that any piece of patient data or health information is quite useless as such alone. It needs context and must be presented with other data as time, place, action, and other information. These are the most important principles. Then the big question is, when planning a repository or national archive, to code or not to code. Coding has advantages if the computer assists the clinician in data processing and decision making, but coding is quite unnecessary if only the clinician and not the computer interprets the data. For instance, if the old lady's cat has died, so it's no use of trying to code this, and it's no use trying to formulate by computer the feelings which the old lady has. It's better to describe them in the terms she uses herself. So unstructured free text is valuable and should not be abandoned. And all of it should not be produced automatically by computer. Well, to the structuring, in this Finnish solution, there are certain items which should be coded or structured in the same way in the whole country. There are two important lists, the list of problems or episodes and the list of drugs, which should always be available. The list of medications also includes previous allergies and adverse reactions caused by drugs. Investigations, laboratory, blood pressure measurements and so on, surgery, procedures, implants, and last but not least, a structured treatment plan, which should also include individual targets set to an individual patient. I will now discuss four different uses of medical record information: for managing patients, for improving service, for supporting research, and also for feeding other information systems. The first part, managing patients, is of course the most important. Shared care by general practitioner and specialist is one of the aims of the national solution. Here is a sketch or a view of the patient record when it is first opened. Here you see the two important lists, the list of episodes and problems and the list of current medications. Actually, the diagnostic label can change within an episode, for instance, to dyspnea, to asthma, and maybe even heart failure when the patient is investigated further. But the episode code remains. You see here is this free text information, and there are also guidelines which have been searched on the basis of the patient's problems. These red dots in front of the guideline heading shows that these guidelines have been updated recently, so it might be worthwhile to look at them. The medical record is a means of communication, and there are messages embedded here in the medication list. There is a message from the patient that he needs a repeat prescription, and there is another message that another doctor in another institution has started a new drug for this patient. So, when there is a structured list of medication, we can click from the short view to a more detailed view. Here we see when these drugs were started, by whom and where, and for what disease. And now the personal doctor can actively approve this drug on his list too, and therefore this color code will disappear. You notice that here the list also includes medications which were used recently, which still could cause, for instance, some allergic problems, and also there is a list of drug withdrawals if the reason was something else than that the patient got better. For instance, we can see that a diuretic was withdrawn because of a rash. So, then the next part is the patient's user interface. We saw quite many and good examples in the morning. One important thing is that the language in the user interface must be lay language which the patients can understand. That means that we need a metathesaurus which changes the terms, even changes the language. Finland is a bilingual country. Part of the population speaks Swedish, and the coded information could be automatically translated into Swedish. Important part is then that there is a lot of explanatory information. There are chapters of the patient's handbook or the citizen's health portal. There are decision aids. For instance, the patient can see his cardiovascular risk and then do an exercise how to reduce this risk with different intervention. And the treatment plan is here also in the form that the patient can understand. And the patient could enter here his pre-consultation questionnaire or web diary of his symptoms. The computer can produce letters, text messages, email messages for patients, which the doctor just accepts. This is for the patient with rheumatoid arthritis who has had some laboratory tests. Then we come to problem-specific views and decision support for the clinician. If we click active this type 2 diabetes from the patient's problem list, we get a problem-specific view. And there is a lot of intelligence embedded in this view. The items shown here are chosen according to the patient's characteristics. There are some basic measurements, but for instance, the complications of diabetes, they are only listed here if they are present. Only relevant information is shown. Targets in guidelines are shown here in color codes, whether they are met or not. Individual targets for the patients, which may be different from the guideline targets, are visible here. And here is a best before date label. If it turns red, it means that this examination should be repeated. It's due. You also see that now there is a list of guidelines, and now these guidelines are on type 2 diabetes. So they have been automatically searched. Actually, we make an exercise with our primary care guidelines collection, how many codes are actually needed to index the guidelines with the same diagnostic labels which are used in the electronic patient record. And one of those labeling systems, the most simple one, is ICPC, International Classification of Primary Care. So we indexed all topics in the guideline collection with these codes so that they were accessible by ICPC codes. Here is the result of the indexing. The number of guidelines that would result by entering an ICPC code in the medical record is shown here, and there were almost 200 codes which returned only one guideline. Then there are several codes which returned a few guidelines, and only 14 codes which return more than 10 guidelines. So, and only 372 codes were used, quite a small number, compared, for instance, to the number of codes in ICD-10 or SNOMED-CT. 50% gave only one guideline, and 93% gave at the maximum of 6 guidelines. Of course, we need some more specific labels to get better hits for the rest. So, the national service includes a good guideline collection. In Finland, we have had electronic guidelines since 1989. We had the primary care guideline collection for more than 1,000 guidelines, a national guideline program, Käypä hoito. We have local guidelines which are linked to the primary care guidelines and national guidelines. These guidelines are evidence-based. We have a collection of evidence summaries, almost 500. Many of them are linked to Cochrane reviews, and we also have a picture library. And all these guidelines are available to nearly all Finnish physicians in one archive on the web. So you can see that here are the national guidelines, and here are the local guidelines, which were searched automatically. But you can also see that there are automatic reminders, for instance, that the patient was started with enalapril, but potassium and creatinine were not determined. So there is a reminder on that. And the Finnish guidelines organizations, they actually have also started to produce a decision support database, which means that the contents of the guidelines are described in the way that they can be written in a program code. Here is the description of the decision support function written by a physician with linked evidence and guidelines. And then a programmer will transform this into JavaScript or Java code, and it will be included in the script library. Here is an example. The input data is here, and the output data is here. So here is the set of inferences which is performed on the basis of this data, and if all these are met, a prescription of metformin is recommended for the patient. Here are the triggering events which should call the decision support engine: calling up a patient on the screen, entering a new drug, picking a diagnosis, ordering a lab test. Also, the doctor can launch it manually, or there may be a batch run for a selected group of patients, for instance, all patients of a specific doctor. We call this virtual health check. And here now we come to audit and improving service, the second use of the medical record. We saw in the morning very good examples of such benchmarking, quality assessment. The system can also be used in a research mode for identifying factors which explain good quality, if all the factors for the medical record can be entered in this analysis. The virtual health check means that all decision support scripts are run on all patients. Then a list is produced of the results to be seen by the personal doctor, and also for filing into the patient's treatment plan for further use. So we come back to the individual, to the structured treatment plan, which is one important set of those national data. So that should always be updated at every encounter, and reminders by the decision support system can be stored as suggestions in the treatment plan, which the doctor then can accept or not. An important thing is that there should be a list of banned reminders which the doctor has decided that are not applicable to this patient. If the doctor is reminded again and again of the thing he's not going to do on this patient, so he doesn't like the decision support system at all. The next use, supporting research. There is a particular problem that in primary care we would need a lot of clinical research, but too little is performed. And one problem is that the primary care physicians are scattered around. They are not working in institutions where it would be easy to carry out research. If all the patient data is coded in the same way in the health records, we could take advantage of a national web tool for recording research data. There would be even an alerting system when a patient would meet the inclusion criteria for the study, and if the doctor has decided to take part in that study. So he would be reminded. Informed consent would be printed automatically. Part of the data would be transferred automatically from the records, and there would be an interactive form that facilitates data entry. Data would be stored in the centralized web server for analysis. A system like this would greatly enhance research in primary care. Surveillance of drug safety would be one of the applications. If the patient's list of medications contains the history of drug withdrawals and their causes, which then should be coded by a controlled vocabulary, and MedStar vocabulary is a good candidate for that. All these withdrawal data could be collected from the records, and the types, frequency, and clustering of causes could be analyzed. The last thing, to use medical record data for feeding another information system. And now I only talk about one specific thing. That's a large clinical database, a database of all patients, let's say all Finnish patients. And here we get a new functionality. If all this data is in a database, we could forecast individual patients' prognosis and response to treatment by comparing their data to the data of all similar patients from the past. And this resembles the way how weather forecasters are made. The weather forecasters, they try to find a similar situation in the past, a similar hurricane, to see what happens. And this could be also done for patient information. So, my last slide is a sort of view for the future. Let's say this is 2015 or 2020 when this is functioning in Finland. Here is the knowledge part. First of all, most of these are already present in some form in electronic databases. What is still missing is the genome database, which contains all the information about functions of genes and their products. You see there are ethical summaries, which we have already started to use for our guidelines. There is a lot of patient information. There is a patient data part, which then also contains the genome map. And I think here you understand that the amount of data will be so large that it will be quite impossible to deal with this information without a computer and without a decision support system. So the patient data and medical knowledge, they are combined with a decision support system. Also the patient can use it, and the result is probably beneficial therapy. After that, we can take the database of all previous patients and make a simulation on the basis of this. And then we get an individualized prediction of the effects of treatment. And where do we need the doctor? We still need the doctor. The doctor is the one who interprets all this data and communicates with the patient, assesses the patient's values and the patient's choices. And as a result of this discussion, will the selection of treatment be made? Thank you.